presentation diseases, acute cholecystitis, chronic cholecystitis, empyema, mucosal carcinoma. But whatever might be the way of presentation, treatment is usually the same, cholecystectomy. Cholecystectomy কাকে বলবো? Roll number 5, বলো তো, what is cholecystectomy? Roll number 5, শুনতে পাচ্ছ? হ্যালো?
জি স্যার, শুনতে পাচ্ছি।
হ্যাঁ, what is cholecystectomy? Is the term known to you or not? cholecystectomy আমরা কাকে বলি?
স্যার ওই যে গল ব্লাডার স্যার কেটে ফেলে সার্জিক্যাল প্রসিডিউরের মাধ্যমে।
Removal of gallbladder.
হ্যাঁ?
So surgical removal of the gallbladder.
Okay, that is excision and removal of the gallbladder is cholecystectomy. Definitely, you should know. We categorize the all types of operation in the mainly 3 form: ectomy, otomy, and ostomy. Ectomy means excision and removal. যদি আমরা ওই অর্গানটার সঙ্গে ectomy যোগ করি, যেমন thyroidectomy, tonsillectomy, mastectomy, appendicectomy, cholecystectomy, prostatectomy. So ectomy means excision and removal of that particular organ. Sometimes we call otomy. Otomy means like gastrotomy, enterotomy, cystotomy. Otomy means we have to open a luminal organ and to close it after dealing the interior or after solving the problem in the lumen. Suppose there is bleeding from the stomach, so we have to open the stomach, we underrun the bleeding vessel, or we repair the bleeding areas, and then we close it. This is called gastrotomy. Suppose there is impacted bolus of roundworm going to obstruct the small intestine like jejunum or ileum. So on laparotomy, we open the part of the gut, we expel out the roundworm, and then we close it. This is called enterotomy. Suppose there is bladder, stone in the urinary bladder, we open the urinary bladder and then we close it. So this is called cystolithotomy or cystotomy. So ectomy means excision and removal of that particular organ. Otomy means to open the luminal organ and to close it after dealing the interior. And ostomy means to open a luminal organ and to maintain it by doing an anastomosis with the skin or with the similar adjacent organ. Like suppose there is gastric outlet obstruction, we do gastrojejunostomy. That is, we make anastomosis or stoma is maintained, communicating stomach and jejunum, gastrojejunostomy. In case of injury of the rectum or carcinoma of the rectum, sometimes colon or ileum is taken out and it is open to expel the content of the colon or content of the ileum in the form of colostomy or ileostomy. So ostomy means to open a luminal organ and to maintain it. So ectomy means excision and removal. Otomy means to open the luminal organ and to maintain it and to close it. And ostomy means to open a luminal organ and to maintain it, either making an anastomosis with the similar adjacent organ, or through externalization, making an anastomosis with the skin. বুঝতে পারছো সবাই?
Yes, sir.
Yes, sir.
Ectomy, ectomy, otomy, ostomy. So cholecystectomy means excision and removal of the gallbladder. এখানে একটা প্রশ্ন আসে যে আমরা দেখেছি যে whenever the patient is suffering from stone in the kidney, treatment is usually nephrolithotomy, that is removal of the stone. But whenever patient is suffering from gallstone, treatment is cholecystectomy. It is not cholecystolithotomy. এটা স্বাভাবিকভাবে তোমার মনে হতে পারে why there is such difference. We have observed that whenever there is formation of the stone in the gallbladder itself is the source of stone formation and is the part which is deformed and defective. So আমরা যদি শুধুমাত্র if we remove the stone, the symptom will not be completely relieved, and moreover within very short time stone will reform because all the machineries for the formation of the stone are there. And moreover, gallbladder is not so much essential for our body function, not like kidney, not like heart, liver. So considering these two facts, that is gallbladder is not so essential, and whenever there is disease in the gallbladder, the symptom will not be relieved, maintaining the if the gallbladder is not being removed, or in case of a stone, if only we remove the stone like kidney stone or ureteric stone, stone will reform within very short time. And that's why the standard treatment for kidney disease and other gallbladder disease is cholecystectomy. So whenever we decide to operate upon this patient, that is whenever we want to do the cholecystectomy, patient has to be prepared. So in general, we can call preoperative evaluation or assessment. In the preoperative assessment or evaluation, first and most important thing, we make the diagnosis, usually by ultrasonogram. Kokono kokono, we can in the most of the time we can see the picture in the ultrasonogram image. So if it has to be confirmed by ultrasonogram. If it is not confirmed, it has to be supplemented by other investigation, including isotopogranogram, CT scan, then MRCP, like that. So diagnosis has to be confirmed. Number two, assessment of the patient fitness for the procedure. That is, whether the patient is fit adequately to have the optimum outcome through this procedure. So we have to ask regarding cardiorespiratory disease, liver disease, including history of jaundice, history of diabetes mellitus and its control, renal problem. So we have to ask to the patient related to major organ related disease, cardiac disease, respiratory disease, liver disease, diabetes mellitus, and renal disease. And we have to examine the patient for anemia, jaundice, pulse, blood pressure, heart, lung, abdomen. And after doing all these clinical examination, we have to go for certain investigation. You know, that is almost a routine test for any operation. Here only special is liver function test. So we have to do the blood grouping, blood count, blood sugar, renal profile like serum creatinine, blood urea, liver function test. Because in many of the times, at least 5 to 10% cases, there may be subclinical jaundice or impairment of the liver function that might adversely affect the outcome of the operation. That's why routinely it is better to do liver function test like serum bilirubin, SGPT, alkaline phosphatase, prothrombin time. X-ray test to see any changes in the parenchyma of the lung, and ECG, particularly if the patient is aged or have the symptom related to cardiac disease. So these are the routine investigation we have to do before cholecystectomy. Then how will really prepare? Preparation key. Number one, preoperative evaluation, including investigation that already uh, we mentioned. Then the control of comorbid condition, if there is any. That is, if there is diabetes, we have to control diabetes mellitus. If there is hypertension, we have to control hypertension. If there is asthma or other diseases, before planning for the operation, we have to control all these comorbid condition. Then we have to take the informed consent from the patient. Informed consent means we have to explain to the patient and attendant regarding the diagnosis, regarding the operative procedure, regarding its complication and outcome. So after explaining all these things, we have to take the consent from the patient, that is countersigned by attending nurse. এখানে একটা বিষয় বিষয় তোমাকে মনে রাখতে হবে, আমরা জানি the cholecystectomy can be done by standard open procedure and laparoscopic procedure. So in case of laparoscopic cholecystectomy, whenever we are taking consent, it is usually routine practice to take an extra comment that patient is agreed to do the open cholecystectomy if the situation demand or if any other complication develop that need immediate conversion from laparoscopic cholecystectomy to open cholecystectomy. First thing, that is patient should not be allowed to take anything 6 to 8 hours before operation. Cleaning and shaving, prophylactic antibiotic like cephalosporin or others. Sometimes if the patient is obese, having the history of deep thrombosis, we can give a antithrombotic measure or prophylaxis against thrombosis like heparin, antiemetic, stocking and others. So whenever we go for cholecystectomy, there are two procedures. One is laparoscopic cholecystectomy that has become a standard option nowadays. In our country, the cholecystectomy used to practice laparoscopically by the early part of 80s in the previous century, in the 20th century. In our country, it is being started from 1992, and now onwards, at present, it become a standard procedure for gallstone disease all the world, unless until it is not contraindicated for some other region. So cholecystectomy may be done laparoscopically, and secondly, open cholecystectomy. Open cholecystectomy sometimes need to be done if laparoscopic procedure is contraindicated or laparoscopic procedure become unsuccessful or laparoscopic procedure creates a perioperative complication that need to be corrected by open procedure. So in this condition, in those situation, we have to do the open cholecystectomy. Cholecystectomy means removal of the gallbladder, excision and removal. So you see, this is the gallbladder, this is the gallbladder, this is the cystic duct, this is the right hepatic artery, this is the hepatic artery. So if we want to do the cholecystectomy, we have to display the Callo's triangle. Callo's triangle, that is bounded above by the liver, below and to the right, that is cystic duct, onto the left, that is the common bile duct and right hepatic duct. And this is being traversed by cystic artery, that is a branch from the right hepatic artery that is going to supply the gallbladder. So if we want to remove the gallbladder, we have to separate the cystic duct and cystic artery. And for better visualization and to give the safeguard of the common bile duct and common hepatic duct, it is essential to identify the structures of the Calot's triangle. If we can identify the Calot's triangle clearly, we can do the cholecystectomy, avoiding the injury to the CVD and hepatic artery. So in these regards, we can say cholecystectomy, open cholecystectomy can be performed by two methods. Duct first method, that is duct has to be dealt first, followed by gradual separation of the gallbladder from the gallbladder fossa of the liver. But sometimes the Calot's triangle cannot be clearly visualized, and it is not very easy to identify the cystic duct, cystic artery, common bile duct. And in those cases, we have to dissect or start our dissection from the fundus and proceed towards the duct. This is called fundus first method. So one is duct first method, and one is, that is, if we ligate the duct, cystic duct and the cystic artery, then we remove the gallbladder from the fossa. This is called duct first method. But if we can do the reverse, that is, we start dissection from the fundus and proceed towards the duct, then we remove the gallbladder from the fossa. This is called duct first method. So in this method, হ্যালো, শুনতে পাচ্ছ?
Yes, sir.
Yes, sir.
Okay.
এখন পাচ্ছি।
Okay. So open cholecystectomy can be done in two ways. Duct first method, fundus first method. Duct first method, that is the usual and conventional, and we can do the fundus first method if the structure in the Calot's triangle cannot be delineated, and it is usually done to avoid the injury of the common bile duct and right hepatic artery and hepatic artery. So What are the conventional incision for open cholecystectomy? You know, before any operation, we have to made an incision. Incision kake bole? Incision means planned cutting of the skin and subcutaneous tissue by BP knife for exposure to the site of operation. And according to the operation, there are standard incision. So for cholecystectomy, the standard incisions are: number one, right subcostal. Right subcostal means we have to give an curved incision about ½ inch below and parallel to right costal margin, starting from the midline up to a point to the anterior axillary line. So this is the right subcostal incision or Coker's incision. Sometimes we made right upper paramedian incision, that is medial to midline. That is a incision made from the right costal margin running ½ inch to 1 inch right and parallel to midline. That is the right upper paramedian incision. Sometimes it can be done by upper midline incision. Sometimes it can be done by right upper quadrant transverse incision. So these are the traditional incision for cholecystectomy, but most convenient one is right subcostal or Coker's incision. Sometimes it may be right upper paramedian, but also upper midline and upper right quadrant transverse incision can also be used. And the another procedure is laparoscopy cholecystectomy. Laparoscopy cholecystectomy, that is the most convenient and commonly practiced. এটা আমরা পরে এক সময় বলবো the procedure. So we can switch over to the other parts. This is the laparoscopic procedure of laparoscopic cholecystectomy. That is the gallbladder. That is the separation of the neck region, and this has to be followed by application of clip and then application of clip over the cystic artery, and then gradually gallbladder has to be removed. That is the laparoscopic cholecystectomy. So one can ask, what are the advantages of laparoscopic cholecystectomy? So there are several advantages. Number one, this is the minimal invasive procedure. You know, for open cholecystectomy, we have to made a big incision, a 4 inch to 8 inch cutting of the skin, followed by a long scar. So in laparoscopic cholecystectomy, we have to open the skin only at 4 port or 4 site, a small port that usually does not make any ugly scar. So this is minimally invasive. So after operation, there is early recovery. You know, in standard open cholecystectomy, patient recovered usually 2 to 3 days. But in laparoscopic cholecystectomy, patient can recover within few hours, 6 hours to 8 hours, at best 1 day. After 1 day, the patient can be
স্যার আসসালামু আলাইকুম। স্যার শোনা যাচ্ছে না, মাইক্রোফোনটা অফ হয়ে গেছে।
হ্যালো, হ্যালো,
Yes,
শোনা
sir.
যাচ্ছে?
Yes, sir. Yes, sir.
ইয়েস স্যার।
জি স্যার।
কি করে? কি করে? করতে করতে সময় আছে। বুঝছি তো। So advantages of laparoscopic cholecystectomy, already we have mentioned that it is minimally invasive. It recovers early in comparison to open cholecystectomy. After laparoscopic procedure, patient can recover within hours to day. Less postoperative pain that can be controlled simply by paracetamol, and faster return to normal activity. After laparoscopic procedure, patient can return back to normal activities within 7 days. But in case of open cholecystectomy, it might take about 1 month. Minimal scar and cosmetically it would be better. So these are the advantages of laparoscopic cholecystectomy: minimal invasive, early recovery, less postoperative pain, faster return to normal activity, and minimal scar and cosmetically it would be better. So these are the advantages of laparoscopic cholecystectomy. আচ্ছা, ঠিক আছে, ঠিক আছে, দাঁড়িয়ে বারবার কেটে যাচ্ছে। আসলে ইন্টারনেট connection is not working properly. Frequently it is going to disrupt. সবাই, so on this ground laparoscopic cholecystectomy is better in comparison to open cholecystectomy. So after cholecystectomy, what would be the result? Usually cholecystectomy gives complete relief of symptom. Operative mortality is less than 1%. Risk factor in terms of complication is advanced age, comorbid condition, acute presentation, and technical fault. Complication may be 10 to 15%. So post-operative complication, the common documented complication after cholecystectomy are: number one is hemorrhage. Hemorrhage usually occurs either from the cystic artery or hepatic artery occasionally, and commonly from the liver bed or accessory cystic artery. So there may be hemorrhage from the cystic artery, accessory cystic artery, or liver bed. Number two, infection. Number two, infection that is uh, usual happening after open cholecystectomy, but after laparoscopic cholecystectomy, this is not the usual complication. So the common postoperative complication after cholecystectomy is number 1 is hemorrhage, number 2 infection, number 3 the injury to the liver, bile duct and hepatic artery, sometimes intestine. So these three are very common complications that might occur after cholecystectomy. Next one is retained stone. Retained stone, that is, it is missed to demonstrate the presence of stone in the bile duct and it remain within the bile duct. This is called retained stone. Post cholecystectomy syndrome, that is a symptom complex that develop or going to persist even after cholecystectomy operation. যে সিমটমের জন্য সে আসছিল, this similar symptom or new symptom going to persist after operation. That is, as a whole, it is called post cholecystectomy syndrome. Then post cholecystectomy choledocholithiasis. You know, sometimes the stone might form in the bile duct. আমরা জানি যে bile ductের মধ্যে stone তৈরি হতে সময় লাগে usually 6 months. So after cholecystectomy, if we demonstrate that there is stone in the bile duct and if the time is within 6 months, it is usually assumed the stone really it is formed and present before operation. But if the stone choledocholithiasis is present for beyond 6 months of previous operation, then we can say this is a new stone form after the operation. So this is post cholecystectomy choledocholithiasis, sometimes incisional hernia or port hernia. So after cholecystectomy, these are the common complications: hemorrhage, infection, injury to the bile duct, hepatic artery, intestine. Sometimes there may be retained stone, post cholecystectomy syndrome, post cholecystectomy choledocholithiasis, and incisional hernia, including port hernia. So internet is not working very nicely. I'm going to conclude today at here. Have you any question? তোমাদের আর কোনো question আছে যতটুকু বললাম? Hello. Roll number 10. 10K, roll number 10. Have you any question regarding the operative treatment of gallstone disease? Any question?
No, sir.
No.
Sir, I have a question.
What is the question?
Sir, is there any possibility that gallstones can be dissolved without a surgical procedure?
Definitely. Already we have discussed that part of the treatment. That is, we know from the pathophysiology of the gallstone diseases that a greater part of the stone is formed by the cholesterol, which is soluble in bile salt and bile acid. With this, utilizing this principle, there was a therapy treatment we call oral dissolution therapy. In this therapy, there is use of deoxycholic acid and deoxycholic acid in the form of tablet. 1 tablet twice daily for 2 months and more. This is nothing but the bile acid, and this bile acid going to make the cholesterol in solution. So With this therapy, some of the very small and well-functioning gallbladder, cholesterol stone can be resolved and the problem can be overcome. But it is being observed that even after oral dissolution of the stone, there is strong possibilities of recurrence. Within প্রতি 6 মাসের মধ্যেই there is increased incidence of recurrence, and by year of 2 to 5 years, all cases there is recurrence of the stone, there is reformation of the stone, and sometimes symptom is not even relieved, and that's why oral dissolution therapy is not become polarized. Moreover, oral dissolution therapy might complicate with the formation of the carcinoma of the colon, and that's why this oral therapy is no longer popularized throughout the world. It is the laparoscopic cholecystectomy that become the standard for the treatment of gallstone disease. Could you understand?
Thank you, sir. Thank you, sir.
Thank you. Any other question? Roll number 20. Roll number 20.
Yes, sir.
আচ্ছা, বলো তো, আমরা দেখেছি যে there are established complication which might develop after cholecystectomy, after open and after laparoscopic cholecystectomy. এই কমপ্লিকেশন গুলো কিসের সঙ্গে রিলেটেড? What are the relating factor for the development of this complication? আমি তোমাকে হিন্টস দেই। তোমরা জানো ল্যাপারোস্কোপিক প্রসিডিওর করার জন্য আমরা there are different sets of maneuver and use of different instrument. প্রথমেই আমরা করি যে ক্রিয়েশন অফ পোর্ট, umbilical port, epigastric port, right subcostal port, right lumbar port. These 4 port, initial 2 port 10 millimeter, later the 2 port 6 millimeter. এই পোর্ট যখন ঢোকানো হয়, there might be injury to the gut. So complication গুলো related, 1 number related to insertion of the port. Number 2, whenever we after inserting the port, we make the abdomen distended by creating pneumoperitoneum. Carbon dioxide gas is inflated. Because carbon dioxide is less toxic, it is non-inflammable. But there might be development of some complication related to this pneumoperitoneum. তার মধ্যে এটা হতে পারে carbon dioxide embolism, there might be cardiac arrhythmia, there might be cardiac suppression. So these are the complications related to insufflation or pneumoperitoneum. Third one, আমরা যখন dissection করব, particularly the area of the Callows triangle, there might be injury to the gallbladder, injury to the cystic artery, hepatic artery, or hepatic duct, common bile duct. So complication might be related to dissection
Yes.
by hand instrument. Number 5, হইতে পারে অনেক সময় আমরা কটারি করি। The bleeding point is controlled by cauterization. অনেক সময় dissection is made by thermocautery or electrocautery. So there may be inadvertent অথবা injudicious injury to the intestine and other structures. So complication might be related to use of diathermy. So আমরা যে complication গুলো দেখি, that are usually related to insertion of the port, creation of the pneumoperitoneum, dissection of the area, including application of the clip and ligation, then use of diathermy. So one should have to be very much careful regarding use of this instrument, and these steps has to be followed critically so that the procedure can be done without complication. ঠিক আছে?
Yes, sir.
So today I'm going to conclude here. If you have no more question, internet is not working very nicely. আর কোনো question আছে তোমাদের? So goodbye and see you again tomorrow. Thank you. Walaikum Assalam.
Assalamu alaikum, sir.
Walaikum Assalam. Percentage দিয়ে দিও।